Hello, everybody. Welcome. Welcome again. I'm just saying again because, this has been a series, like Rita said. We went through normal physiological childbirth. That just means normal childbirth, how it would progress, textbook progression of childbirth. And today we're going to go through medical interventions. Okay, so I'm going to quickly introduce myself again. If you haven't been to any of the previous classes. My name is Zoerina. I'm a registered nurse. I'm also a certified childbirth educator and a certified doula. I've been doing this work for about 8 years now. So I am very passionate about birth just in general. Um, and I'm really, really passionate about teaching what I know about my experiences with births. So today we're going to talk about medical interventions. Well, it's going to really be, hold on, this might not be the right slideshow. Hold on. This doesn't look right. Sorry, guys. Like, this might not be the right one because this looks like it's a little bit different than what I had already put up here. Okay. I think this is it. Okay, sorry, guys.
It's okay.
Sorry about the little tiny mix up. Okay. Okay. So our topics are going to be medical interventions such as pain medications, augmentation of your labor, so induction of labor, and also we're going to touch on the benefits and the risks and alternatives of each one of these things, and operational labors as well, births as well. So that's why I have this picture over here. Sorry, my picture's a little foggy, but I really want you to focus on the benefits and risks and alternatives of each one of these interventions I'm talking about here today. Also, the handout that I shared with Rita kind of delves into some questions to ask yourself about each one of these interventions. And I want you to tap into your intuition as you're hearing this information as well. How does it feel? Like, how do you want to approach this individual intervention, right? And then in the moment or when it's presented to you, you can think of what are the next steps, right? So if you do nothing right now, or if you do move forward with it, what will happen? What are we trying to do with having this intervention? Okay, so that is like just the kind of like the gist of what we're gonna get at today, and I'm gonna break it all down here. So I'm going to talk about what to expect when you arrive at your birthing location, fetal monitoring, labor augmentation, pain medications, and also assisted births. Okay, so when we think about medical interventions during birth, people typically might think about like an epidural or something like that, but there are a lot of other interventions. Going to the your birthing location, or in most people's cases, the hospital is a medical intervention, right? They start putting you on a monitor and things like that. So I really like to emphasize that there are a lot of different things that go into it when you go into the hospital. So, what should you expect when you go to the hospital? So, this is generalized, obviously. Every hospital is a little bit different. They generally have all of these steps once you get to the hospital. So, you either come through the main entrance or the emergency room entrance. So, please understand most of the time your hospital's main entrance closes, usually at about like 9, 10 p.m. for most places. So, they will either have like an L&D entrance, like a maternal and child health entrance, and or you would go through the emergency room entrance. Okay. So just understand that when you're planning everything logistically, where exactly you should go. That's also why it's really important to call your provider when you are on your way to the hospital, because they will tell you exactly where to go as well. You should do also a dry run to your hospital in different types of traffic, different types of routes as well. You will obviously, most people do have GPS. However, it can be really taxing if your GPS is continuously rerouting you, and you're nervous, and you're in labor, and it's going to be taxing on not only on you but also on your support people as well. So you really want to make sure you logistically have that down. I know that sounds like I'm nitpicking, but it's going to help you. Labor is something you largely cannot control, as we talked about before, and this is something that you can control. You can control the planning of where to go and how you're going to get there and everything like that. Okay. If you live further away from your hospital, you might want to consider going to your birthing location a little earlier than the average person might go, just because you're further out. So keep that in mind too. Just keep constant communication with your provider. Very, very important. So once you get to the hospital, they'll send you to L&D. So they'll know if you're pregnant, you're having a baby. They'll just send you right up to L&D. They'll give you instructions on where that is. You will then go into a triage room. So a triage room or area is just the emergency room, but for people who are pregnant. That's the only difference. Okay, so they'll take your weight, your vitals. They'll put you on a fetal monitor that I'm going to show you what that looks like in an upcoming slide. They'll also do a vaginal exam to see how far you have progressed. Okay. Most of the time, they don't really want to admit you until you are in active labor. So if you're 2 centimeters dilated and your contractions aren't really uncomfortable, there's not a lot of change going on, they're most likely going to send you home unless there's something wrong with you or something wrong with your baby. Then obviously, then they would admit you to manage whatever that problem is. But for most people are fine and safe and healthy during their labor. So that might be a reason why they might turn you away. Okay. After all of that stuff, they'll put you into a labor room. Now, sometimes hospitals are full. So sometimes you might actually have your baby in the triage room. That does happen to some people. But either way, it's all safe. You're at the hospital, your providers are there, the nurses are there. It should, everything should go pretty smoothly. Okay. So here next, we're going to talk about one of the first interventions that they do is a saline lock or an IV. So this helps us have access to your veins. Okay, that's why we put the saline lock, as you can see right here. It's not attached to anything. It's just the catheter that's placed into your forearm. So in the front part of your arm, most likely. Okay, so we have access to your veins for fluids, pain medications, induction of labor, managing preeclampsia. Okay, and also antibiotics as well. Okay, so these are some of the most common reasons why we might use this. This is standard of care at every hospital that I've ever been to, and I'm assuming it's probably true across the United States that this is standard of care everywhere. Okay, so that's just something to have just in case you need it. I'm going to talk a little bit more about the use of antibiotics in labor. So, a lot of people don't know that the antibiotics are pretty widely used in labor. If you have something called group beta streptococcus, that's what GBS stands for, group beta streptococcus. It's a bacteria that lives in many of our bodies. It doesn't hurt us, it doesn't bother us at all. Many women in the population do have it. However, if your baby is exposed to this bacteria, it can make them very, very sick. Okay. So what we do while you're in labor, we treat you with about 3 rounds of antibiotics. All right. Especially if your water has broken, it's very, very important that you do get those antibiotics to kill off the bacteria so your baby's not exposed to it. If they do get exposed to it, they get very, very sick. In particular, like lung infections, like pneumonia, can happen. Okay. Now, obviously, some people go super duper fast, right? Their labors go really quick. So either they don't get all 3 rounds or they don't get any of the antibiotics at all. Well, in that case, your baby will be very closely monitored. Okay. And we do have treatment plans for those babies as well if they do end up getting sick. Okay. This is a preventative measure. If you have a fever or infection, so that would be like we would know that when we check your temperature. We check your temperature very frequently during labor, especially after your water breaks. We check it even more frequently to manage this. So if you do have an infection, we will be checking for that. And the reason why we do it more when your water breaks, remember we talked about last time or in one of our previous classes that the bag of water is a seal, right? It protects the baby from the outside world, right? So infections cannot penetrate that area. Well, if the bag of water is gone, then now bacteria can get up there, okay? And that's what causes the fever or infection. And then finally, prophylactically, that just means preventatively for cesarean sections. Okay, so those are the reasons why we use antibiotics in labor. Here we're going to talk about external fetal monitoring, okay? If you've already been to the hospital before or you've had a baby before, you have seen this before, right? This is like the classic fetal monitor right here, okay? This top piece right up here is called the tachometer. That tells us if you're having contractions. The bottom piece right here is the ultrasound. It tells us what baby's heart rate looks like, okay? Normal baby heart rate is anywhere from 120 to 160 beats per minute, okay? So that's normal baby heart rate. That's what we like to see on the monitor, all right? So that is standard of care everywhere, right? All hospitals across the United States, you will be placed on this monitor at some point during your labor. Another alternative is Doppler monitoring. This I don't really see too much in my hospital births. So most hospitals don't really do Doppler monitoring. What they will do is well, or when I do see it, is if you have midwives who are caring for you, or if you're doing an out of hospital birth, so at a birth center or at a home birth, that's where I see this. So this just tells us your baby's heart rate, okay? And that's not continuous. So this is more, you're able to have continuous monitoring with this electronic fetal monitoring. But here you don't, right? You're just every once in a while the midwife will come in, check you, and then leave the room again. And this is just right here an example of a mobile fetal monitor. Okay, so this is just a monitor you're able to use to easily be able to walk around. So you're on the monitor still, so it looks like this, right? But you're able to move around. Okay, these are not super duper common, but it's common enough that I do like to talk about it. If you do have access to one, it allows you to be on the monitor continuously without being kind of like stuck in bed. So with this monitor, you can't move very far. Do have to like, plug it out to be able to use the bathroom and things like that. So that is one of the drawbacks of being on this classic fetal monitor. Okay. I'm going to talk a little bit more about intermittent and continuous fetal monitoring in a second here, but that is, again, the great benefit of having this. So you're on the monitor, but you're able to move around a little bit more and a little more freely. Okay. So those are some examples of external fetal monitoring. This is an example of a modern day mobile monitor. So this is fairly new. I feel like I started seeing these about 5 years ago at my hospital births. So it's called a Novi. That's what this particular brand is called, Novi. These little electrodes are stuck to your belly, and this little tiny monitor right here is stuck a magnet onto your stomach, onto these electrodes. This sends a signal to the iPad looking device right back here, and it tells us you're having contractions and also if your what your baby's heart rate is. So similar to this previous slide right here, you're able to move around and have continuous fetal monitoring if needed. Okay, so that's a really great benefit of using this. You would ask your individual hospitals if this is something that is available to you. It's not super duper common. Even if your hospital does have this available, you still might not be able to use it because this part of it, you see these little white patches right back here, the electrodes that I was talking about, that part of it is disposable. So they would, every time you use it, they throw it away. So sometimes the hospital that you're going to just doesn't have that that resource at that time. Okay. So even if you do have it available to you, don't count on necessarily being able to use it. Okay. But again, great thing about it is that you can move around and be on the monitor continuously. And it does the same thing that the other external monitors do. So what are they looking for when they're monitoring you? Well, looking if your baby's placenta is functioning during labor, okay? So if a baby's heart rate is reassuring, so remember this 120 to 160 beats per minute, right? In between there, well, that means that you are getting the baby's getting oxygen during labor. That's great. That's perfect. We want the placenta to be functioning very, very well during labor. If there's a problem with the cord, right? What if there's like, a knot in the cord or the baby's laying on the cord a little bit funny, right? That can affect their heart rate. We would know that as well. Look by looking at the monitor. And then how is your baby reacting to contractions and interventions as well? Okay. So here is just an example monitor right here. These are three different babies. Okay, so these three different colors are three different babies. So your baby's fetal heart rate would be at the top right here. And down here are the uterine contractions. Okay. So this is telling us if you are having a contraction. So I don't expect you to memorize this. This is just kind of like a little crash course of some things that we learned in nursing school. But here we have late deceleration. So the peak of the deceleration is after the peak of the contraction. So that is typically a sign that there's something wrong with the placenta. What we do there is that we give you more fluid. Okay, so we do intrauterine, something called intrauterine resuscitation. Okay, so that helps increase fluid volume and helps the baby out with their heart rate a little bit. Here we have in the purple variable deceleration. So that's a sign that there is something going on with the cord. We might do intrauterine resuscitation here as well, but we also will change your position, right? So most likely in most of these cases, the baby's just kind of laying on the cord funny. If you just flip over, the baby's not laying on the cord anymore, right? So that's what we have there. A lot of times you will see some variable decelerations during your labor, which is perfectly normal. And then here we have early decelerations. That just means your baby's head is getting compressed. So especially when they get into the pelvis, when you have a very strong contraction, that compresses their head. Okay, so the peak of the deceleration matches the peak of the uterine contraction. Okay, and that is what that looks like. So that is pretty normal as well. Okay, so again, I don't expect you to memorize this. I'm just kind of giving you an idea of what they're looking for on this monitor, and also giving you an idea or telling you that all decelerations aren't necessarily bad, right? Babies' heart rates are variable, and that's okay. We want to see variability in the baby's heart rate. Okay, as long as they always turn back to baseline in between 120 to 160 beats per minute. Here I have internal fetal monitoring. Okay, so internal fetal monitoring is a little bit different than external. So these monitors go inside of you. So I'm going to talk about the benefits and the risks of each one of these. Now, these are not used very, very commonly. So it's not super duper common that you would use this. However, if you're higher risk and your baby is higher risk, then you might actually have to use one or both of these monitors. Okay. First one I'm going to talk about is the fetal scalp electrode. The benefits of this monitor is that it records more accurate data of the baby's heart rate. So let's say that the baby's heart rate is throwing out these decelerations, like these variable in the purple right here that I showed you right here, right? Let's say the baby's throwing out these decelerations. Well, we will use the fetal scalp electrode to see if that is in fact true, okay? Risk include infection and injury to the baby as well. They do have to break your water for them to be able to use this monitor as well. So the things that come with them breaking your water, like the higher risk of infection and things like that, also come with this, okay? So this is attached to your baby's scalp. It is just like a little splinter. That's all it is. It doesn't go super duper deep into their scalp or anything like that. It's again, just like if you got a splinter, that's how deep it goes. This is the end of the monitor. So this is the piece that would attach to their scalp. Okay. This is blown up. It's not this big. It's a very tiny device. Okay. But I do like to just be transparent about what that looks like when I do childbirth education. Next thing I'm going to talk about is the IUPC. So that's the intrauterine pressure catheter. So with the tachometer, the other monitor that I was talking about that would monitor your contractions, okay? That one only tells us if you're having a contraction. It does not tell us if how strong that contraction is, okay? So when they use this, the most common reason why I see them use this is when we have a mom, let's say that she is stuck at 5 centimeters and it's been like 4 hours since she's gone up or progressed. Okay. Well, If that is happening and we have you maybe on a really high dose of Pitocin, or we're trying to see if we should use Pitocin, we'll use the IUPC to see how strong those contractions are to see if we have room to use Pitocin, which is just synthetic oxytocin. I'm going to talk about that here in a second, okay? But here we use this to gather more data so we're able to augment your labor, okay? See what next steps are. And again, similar risks as well here with internal fetal monitors, okay? So this is the internal fetal monitors. I'm gonna move on to pain medications, okay? So we have our analgesics, nitrous oxide anesthesia, and sterile water blocks here. So nitrous oxide is not widely available at many locations, but if you're lucky enough to be going to a hospital where this is available to you, then this is a really, really great resource for you to manage your discomfort. What it does is it lessens your anxiety about the pain medications, okay? Or sorry, about the pain, okay? It doesn't take the pain away, it just makes you care about it a little bit less, okay? Um, it can be used at any time during labor. It is self-administered, so you must be able to put the mask to your face. All right. It wears off very quickly. So within 5 minutes, it's out of your body. It does not affect your baby for that reason because it's inhaled and it leaves your body very quickly. It doesn't have time to cross the placental barrier. What this is honestly just laughing gas. If you've ever had a tooth pulled, that's exactly what this is. It's just laughing gas. Okay. It can cause claustrophobia for some people, especially when you're towards the end of the first stage of labor. Remember, that's transition, right? Like the feeling of putting the mask on you. Some people don't like that feeling. It can also cause dizziness. However, I've never seen it cause dizziness, but I know that it is a possible risk or drawback. So when you first use the medication, you will be in bed for about 20 to 30 minutes. Alternatives include epidural or saline water blocks as well. Okay, I'm going to talk about what those are in an upcoming slide. And of course, use your intuition and think about needing more time as well with this intervention if you do ever decide to jump in and use it. So this is a great resource. It's available at your birthing location. This is another really great resource, okay, if it's available at your birthing location. So here we have sterile water blocks. It's not super duper common. A lot of midwives, if you are using care from midwives, do know this technique. So what it is, this offers immediate pain relief, and it's great for something called back labor. So I'm going to give you an example of what back labor is. I'm going to kind of show it to you. If you can kind of see my model right here, I think you can kind of sort of see it, but not really. But yes, here we go. That's a perfect angle. Okay, so right here, this is your tailbone. So what happens when you have back labor is that your baby, the back of their head is knocking up against your tailbone. So this is the baby, the back of the head is knocking up against your tailbone like this, okay? Hold on, let me get the baby in here. But yes, you can see that a little bit better right here. Sorry, you can kind of see my background, but you can kind of get what I'm talking about. The baby's back of the head is knocking up against the tailbone, okay? So that's the posterior, the called occiput posterior, okay? So that means the back of the baby's head, the occiput is knocking up against your tailbone, and you're feeling all of your contractions in your back, okay? It's called back labor. This can help alleviate it. Also, epidurals can also help alleviate that as well. It's not super duper comfortable, but as you can see, there are a few solutions to it here. The great thing about using this intervention is that you can stay awake and alert, and it does not affect your baby at all. It's just water. It's just saline water they put into your back. That's all it is. The drawback is that it's not at every birthing location, like I mentioned before. It's painful upon administration and it is not continuous. Okay. So eventually your body just absorbs the water. That's all it will do. Okay. It'll work for a few hours on average for most people. All right. So alternatives to this include epidurals and also nitrous oxide as well. All right. Yeah, I'm sorry, Sad. We'll try. Let me see if I can show you in a little bit better of um, quality. If you can, I'm going to turn off my background for a second. This is what I was showing you before. So it's just like the occiput posterior right here. As you can see, the back of the baby's head is knocking up against the tailbone right there. Okay. So I'm sorry, it was a little, I don't want to disrupt, but yeah, that is what that looks like in a little bit better detail. Okay. So here we have next thing is IV narcotics or analgesics. Okay. So um, a benefit of this is that it offers immediate pain relief. It doesn't take away the pain, it just takes away the sharpness of the pain. Okay. It also lessens your anxiety about the pain as well. This medication can lower your blood pressure because what this is a central nervous system depressant. So it lowers your blood pressure, lowers your breathing rate as well. It can cause respiratory problems for you or for the baby. That is why it's only given in early labor. We don't want to give you this medication in your IV and then your baby's born an hour later and then kind of come out sluggish and have a difficulty breathing and things like that. That's why we only give it to you in early labor. Okay, so that is 5 centimeters and below. Okay, that's it. All right. Once you hit like even some in some cases that if you go above 5, if you hit 5, they're not going to give it to you. Okay. So keep that in mind. When I see people use this, most of the time it's like if you have a augmentation to your labor, like a labor induction, and you're still in early labor or you're not in labor yet. So this can cause nausea and dizziness. And of course, the alternatives include epidurals, nitrous oxide as well. Okay. So most people don't end up using this, but just so you know, it's an option. Okay. So that is nitrous oxide. I'm going to talk, oh, sorry, IV narcotics. Now I'm going to talk about epidural. So what an epidural is a type of anesthesia that provides continuous pain relief through a small plastic catheter that is placed in the epidural space of your back. Okay. Here we have the needle, the epidural needle, what this looks like. And the catheter, as you can see right here, is going into the epidural space. So this is the space right before the sac that holds your spinal cord. Okay, so that's where it is. Here's the process of getting an epidural. I know this is a lot of words, and I'm going to, I'm going to go through pretty efficiently. But I like to put this up here so you can understand that it's not like you walk into the hospital and then, oh, you just get an epidural. That's not how it works. Okay, there's a process that goes into it. All right. So you have to ask for the epidural, and then your nurse and or your provider will put an order in for it. You must get 2 to 3 bags of fluid before you get an epidural. The medication that's in an epidural is also a central nervous system depressant, so it lowers your blood pressure. Okay, so we give you more fluid to bring up your blood pressure on the front end. Okay, so it kind of balances out before you get the medication. Then your anesthesiologist or your CRNA will come in and assess you. Your lab results must be available for them to proceed. So your lab results have to come back. That's a part of the process. Again, that's why you can't just walk in and get an epidural. You curve your back like a quick shrimp. So you curve over a pillow. All right. There are two different needles involved, one to numb your back and the other to thread the catheter into your back. So this big needle is not just the first needle they put inside of you. There is another needle that numbs your back beforehand. So don't worry about that being too uncomfortable. All right. And then once they get the catheter in, it usually takes about 5 to 10 minutes. They will do a test dose and it'll feel like a waterfall is coming down your back. You'll get a patient controlled administration remote. Okay, so it's just a little button that you press to get a bolus or extra medication. Don't worry, you cannot overdose yourself because it stops after a few presses per hour. Okay. And then you have to lay on your back for 15 minutes after they place this epidural. All right. So we want to make sure it's on both sides. That's why they do that. And then your nurse will insert a catheter into your bladder because you can no longer get up and use the bathroom yourself. You won't feel the sensation to urinate. And also, you cannot get up and walk anymore. So that's one of the drawbacks. Now I'm going to get into the drawbacks of having an epidural. Is that you cannot walk with an epidural. You can't stand up. You don't know how much force it takes for you to stand up and walk around. We do it every single day. Most people here, I'm assuming, are able-bodied people who walk around every day. So you don't know. You're used to doing that, right? But if you can't feel your legs, then you don't know how much force it could take, and then you just fall right over. Okay, so that's one of the reasons why you can't get out of bed using an epidural. Some benefits include that it offers effective pain relief. They call it the Cadillac of anesthesia because you're able to be awake and your pain is managed while you are in labor. This can be used for labor of any length at any time. It does not cause any breathing issues for baby because instead of it being in your IV, it's localized pain relief in the epidural space of your back. Okay, it's easier for you to rest and relax. Typically, people get an epidural and go right to sleep right after. Okay, and then it can also be used for surgery. So they would just give you more medication, okay? So it's able to be used for surgery if you do need to have a cesarean section. Some risks and drawbacks is that it can slow down your labor. And the reason why it can, remember, if you remember from our previous sessions where I talked about that positive feedback loop, remember oxytocin works on a positive feedback loop. So as your body releases oxytocin, it releases more and more and more until you have a baby. Well, one of the things that triggers that positive feedback loop is the force of the baby's head, like feeling the force and the pressure of the baby's head on the cervix. If you can't feel that anymore, your body's like, oh, the positive feedback loop can slow down or it can stop, right? Because it doesn't feel that sensation anymore. Okay. Now, most people, their contractions pick right back up. Okay. But some people do need augmentation of the labor, and that's just Pitocin. We'll just give you synthetic oxytocin to jumpstart your labor again for that. Okay. You also need a continuous IV to continuously manage your blood pressure. So we'll also be checking your blood pressure more frequently. You'll have continuous fetal monitoring and that urinary catheter that I was talking about before. And it can prolong that first stage that I already talked about, but also the second stage. If you cannot feel the legs, similar to why you can't walk, it's you don't know how much pressure to put behind your pushes. Now, with an epidural, you will most likely still feel pressure. Okay, so it takes away the pain. We can take away that, but we can't necessarily always take away the pressure. Most people do feel some pressure, especially when the baby is really low in the pelvis and in the birth canal. Okay, so you will most likely still feel that. All right, but it can so the great thing about that is that it's easier for you to be able to push with that sensation, okay? But it can still be hard to like master pushing because you think that you're pushing really hard, but you're not because you can't feel, right? Um, Ineffective pain relief. So, like I said before, some cases it works on one side and doesn't work on the other for some people. It can also lower your blood pressure, like I talked about before, and you can have something called an inadvertent spinal block. So that is where the catheter goes a little bit too deep or it pokes a hole in the sac that holds your spinal cord. And that spinal fluid leaks out into that space and it causes you to have extra absorption of the medication. So your legs will be extra dead and it'll feel like very, very heavy. But it can also cause you to have something called a spinal headache the next day. Okay. So that is a piece of what comes with this. Nitrous oxide and sterile water blocks are alternatives to this. And don't forget to use your intuition and think about the timing. Typically, the best time to get an epidural for most people is about 5 centimeters dilated. So when you have consistent progress, your contractions are coming very, very consistently because once you get the medication, it's more likely that your contractions will space out, right? And it kind of like slows down your progress a little bit. So it's better for us to space out a contraction pattern that's really, really close together versus one that's super duper far apart. Okay. But honestly, truly, the best time to get it is when you feel like you need it. Okay. Some people walk in for an induction and immediately get an epidural. You can absolutely do that. If you feel like that is what you need, then absolutely do that. I just like to talk about the risks and the benefits of everything so you understand what you are consenting to. Okay. So that is epidurals. All right. If you have any questions, you can put them in the chat. I'll also be answering questions at the end as well here. Here we have spinal anesthesia. So spinal anesthesia is used for planned cesarean section. So if you're having a planned cesarean, we'll use this medication. So instead of a catheter being placed into your back here, you only have an injection of the medication into your back, okay? And also maybe some medication given to you IV as well, okay? So this spinal anesthesia works for about 2 hours. So it's not continuous because there's no catheter. So it only works for about 2 hours. So that's about the duration of a cesarean section. Okay. Then here we have general anesthesia. affects the whole entire body. Less than 1% of the 30% of people who get a cesarean section need this type of anesthesia. But this is for people who either do not qualify for an epidural or this is an emergency and we need to get the baby out fast. So we need to put you under. Okay. And again, incredibly, incredibly rare. Most people do not experience this. I have even really seen it in all of my experience. But I do again like to talk about it because it is a possibility for some people. Okay. Right, so now I'm going to talk about medical augmentation of labor, and I'm also going to talk about labor tools as well. So operational labor as well here. So why would you need medical interventions outside of pain medications? Okay, so induction, right? Reasons for induction. So this is just a list of reasons. Post dates, that just means you went after your due date. Preeclampsia, that's just a disease in pregnancy or labor, even in your postpartum period that is characterized by having high blood pressure. Intrauterine growth restriction, the new term for it is fetal growth restriction. Okay, prolonged premature or pre-labor rupture of membranes as well. So that means that your water broke, okay, and it's either premature, right? That means that the baby is not full term yet, or that your water broke and you're not having any contractions, which is also possible as well. So if you have an extended period of time, all right, with your labor, with your membranes being ruptured, the baby can't really tolerate that for a long period of time, so we would induce you. Okay. Elective induction as well is something that can happen to some people. Being tired of being pregnant is not a reason to get induced, though. Okay. I know a lot of people ask that, but it's not a good reason why. It's usually a medical indication for us to induce you. Okay. Gestational diabetes. The main concern there is that the baby gets too big. And finally, RH disease. So RH disease is largely eradicated in the United States. However, this is just my little public health announcement to take your RhoGAM shot. If you are RH negative, you would know you're RH negative. Your provider would have told you by now that you are RH negative. Make sure you get your RhoGAM shots, please, to prevent. Okay. So now I'm going to hop into the the induction of labor piece. All right, so this is a little bit about your estimated due date. Essentially, what I'm trying to say here is that you are term, right, at 37 weeks. However, we want the baby to cook a little while longer. Most first-time moms do go a little bit past their due date, okay? An estimated due date is just that, an estimation, right? So you can go a few days past your due date, and most first-time moms do that, okay? However, when we hit 41 weeks, 42 weeks, right, when you get to this post-term area, late term area, that is a little bit concerning because what happens there is that the placenta gets old, right? The placenta is a temporary organ. It's not like your brain or your heart that you're supposed to have for your whole entire life. This organ is just there to sustain the life of the baby while you're pregnant. So eventually it will do something called calcify. Okay, it'll harden. It'll start to harden in little tiny areas. And those areas do not give the baby oxygen. Okay. So that affects how well your baby can tolerate labor. All right. So that is why we do like to induce you once you get to this late term, post term area. We don't really want you to get there. Okay. One of the reasons why. So I'm going to start from the least intense to the most intense. So a membrane sweep is something that you can get done in office, right? A few days before your due date, or well, I shouldn't say before you do it, or before an induction of labor, or a little few days after your due date, like your provider might want to like jumpstart some things. So what this does is it releases your own personal prostaglandins to soften your cervix, okay? And it can jumpstart labor, all right? Risk and drawbacks is that it's uncomfortable to get done. So it is a vaginal exam. They use sterile gloves, a vaginal exam. They have to remove the membrane that anchors the amniotic sac to the uterus. Okay, so they have to reach really, really far up there and get rid of that whole entire membrane. Okay, so that is what makes it very uncomfortable. It can cause infection. They can also accidentally break your water. I've never seen that done, but I just know it is a risk. And it can also cause something called prodromal labor. So this has a 50-50 chance of working, okay? In 50% of the cases, it works fine, it works great. You go into labor and it's totally fine, right? But the other 50%, you'll have this prodromal labor where you're having contractions here and there. It's uncomfortable, but your cervix is not changing, okay? So if your cervix is not changing, you're not in labor, all right? So in that case, you would just have to like kind of wait for things to pick up or wait for your induction date. Okay. Alternatives including waiting. So when your body just naturally says it's time to go, then that's when it's time to go. Medications are also evening promozoal. Remember, evening promozoal has nutrients in it that are the building blocks to prostaglandins. And remember, more prostaglandins equals a more favorable cervix. The cervix will be softer. Okay. So that is just some things you can do as an alternative. You must be dilated at least 1 to 2 centimeters for them to be able to do this, and your provider must be able to also reach your cervix to be able to do this. So not everybody can do this. It's just an option for you. Okay. And yeah, so some people, so the point of a membrane sweep, I was just going to actually get to that. I saw that comment in the chat. The point of a membrane sweep is to help soften your cervix, right? If you know you're going to get induced anyway, this can only help you. Like it's if it's going to happen, they're going to break your water anyway. They're going to give you the medications or whatever it is anyway. It's better to go into your induction with a more favorable cervix than go into your induction with a really hard cervix that's like not. It's going to make you need more medications. Yeah. And have a longer induction for most people, right? Everybody's different. That's just my little 2 cents about it. You always do what is best for you, okay, and what your provider says to do. All right, here I'm going to talk a little bit about the Bishop's score. So obviously, these are all things that we talked about in the previous um, iterations of our previous, to say, classes. But here, so the higher this number is, the more points you get. Okay. Here we also have the rightness of the cervix. So that's why I have an avocado in the corner because your cervix should be soft and the position also should be moving to the front. Okay. So these two things together tells us that your body is ready to go into labor. If you have a Bishop score over a 9, that means labor will begin spontaneously. If you have a Bishop score between a 4 and an 8-ish, that means that induction would probably be needed for your labor to start. And if you have a Bishop score of a 3 or below, then you need cervical right verse. Okay. So lower your Bishop score, the more interventions we have to use. So that's where I was talking about with the membrane sweep. The membrane sweep helps heighten your Bishop score. Okay. And it just makes your cervix more favorable for those medications. So that is uh, some things that you can do to induce, or sorry, not things you can do, but a number you can ask for when you're discussing your options for medical interventions with your provider as far as induction goes. So now I'm going to talk a little bit about how an induction typically progresses. So you would probably come really, really early in the morning or really, really late at night. All right. Then you would, let's say you do have a lower Bishop score. Well, then you would use cervical ripening agents. So either Cytotec, so that's this little white pill right here, or Cervidil. Okay. So these two things can soften your cervix. Once the Cytotec is inside of you, that's it. It dissolves. We can't do anything about that, right? So that's one of the major differences between this and Cervidil, right? Cervidil just periodically releases the medication using this little flat tampon thing. All right. If your baby doesn't react well to it, we can just take it out. Okay. But however, most providers prefer Cytotec because it's more, the best way I can put it is efficient. It's more powerful. Okay. And you would get a dose every 4 hours. Okay. Every 4 hours of Cytotec for the span of 12 hours. Okay. And then with Cervidil, you can have 1 or 2 of these every 12 hours. Okay, that's another one of the major differences. However, again, most providers prefer Cytotec. Once we soften your cervix, we might use a Cook catheter. right? This catheter right here, this balloon. This device has two different balloons. We blow it up with saline water, and we get you to a manual 4 to 5 centimeters dilated. Okay, so a manual 4 to 5 centimeters dilated. And then once that happens, it just falls right out. All right. And I call it manual because your body can snap back. Your cervix can just snap right on back. All right. That is why we also like to use Pitocin, which is synthetic oxytocin, to help you have contractions. So that's what that thing does. It makes you have contractions. Okay. They release it similar to a positive feedback loop. So every 30 minutes, they increase the amount of Pitocin they give you every 30 minutes until we see that you have 5 contractions in 10 minutes. So that is a consistent contraction pattern. All right. The point of using Pitocin is that it's supposed to jumpstart your labor. Okay. If you're using a bunch of Pitocin and your labor is not jumpstarting, your body's not taking over, that is sometimes a bad sign. Okay. It doesn't mean you can't have your baby vaginally, but it just means that your body really needs a lot of Pitocin to respond to the medication. Okay. Final thing we can do also is break your water using an amnio hook. So this little hook device pokes a hole in the bag waters and snags it away. The point of this is that the baby will put more pressure onto the cervix. Okay. And again, that helps with that positive feedback loop. Okay. And we're trying to encourage that descent. Okay. Because sometimes the baby can kind of be bouncing around in their amniotic sac. All right. So that's why we get rid of it in some cases as well. So these are just some things that we can do. It can take up to 24 hours for your labor to start with an induction. Okay. Not for you to have your baby, for labor to start. Okay. Not saying that happens to everybody, but it does happen to some people where their body takes a really long time to respond to that medication. Okay, so make sure that you heighten your Bishop score as much as you can beforehand by softening your cervix, and that you are wrapping your head around how long it might take. So here's some benefits and drawbacks that I kind of touched on before. Some drawbacks of having an induction of labor, especially with Pitocin, is a uterine rupture. It might not work, your body just might not respond to it. Increases the risk of more interventions being used, possible longer hospital stay. The contractions can also be more painful for a lot of people because when you are getting Pitocin, that's in your IV. Okay, you're not getting it through your brain. So naturally, your body releases oxytocin through your brain and it crosses the blood brain barrier and helps release endorphins, which are our natural calming and relaxing hormones and pain relieving hormones. So, since you're not getting that, it is more uncomfortable. And also, you will be experiencing essentially a transition contraction pattern, right? A really, really close contraction pattern, but you're only 5 centimeters dilated. Okay, so you would be experiencing that discomfort, that level of discomfort for a longer period of time. Okay, so instead of feeling that towards the end of your labor, you're feeling it towards the middle of your labor. Okay, so that's also something that can happen. The contractions can also come too frequently. We do have a solution for this. This is called terbutaline. Just give you a shot of it in your thigh. Okay. Benefits of this is that augmentation of your labor can occur. It can shorten the length of your labor in some cases, and it gives your providers a little bit more control over the situation, especially if you have gestational diabetes or preeclampsia or something like that, where the solution to those diseases is to deliver the baby. Okay. I'm going to talk about some of these alternatives next. So here we have natural induction methods. So nipple stimulation because that releases oxytocin. Sex because the semen has prostaglandins in it, and the prostaglandins soften the cervix. And of course, doing things that make you happy. Okay, so that releases oxytocin naturally as well. If you have any questions about other forms of natural induction methods like herbal medicine and things like that, I'm not an herbalist. You should absolutely talk to your provider about that to get more information about that. Okay. Yeah, so that thigh shot is called terbutaline. It's just to help your contractions come closer together. Or sorry, not closer together, to space out. Okay. So that's why we give it to you. Your contractions are coming too frequently. Okay. So now I'm going to talk about assisted birth. This is the last thing I'm going to talk about. So I just have a few more slides. Here we have assisted vaginal birth. This is only done if your baby is low enough That is it. It's the only time that we would do this. Okay. This is used during times of fetal stress. All right. So here we have a vacuum. This allows for you to have a vaginal birth. And it's also typically faster than getting cesarean. So if your baby's head is low enough, they're not progressing, they're not rotating, maybe they're occiput posterior. So your baby might be occiput posterior through your labor, but they should rotate, okay, to be able to deliver, right? To get into the birth canal and be born, right? So this helps you get a little bit of help, especially if the baby's not rotating or they're in a funny position. Swelling, bruising, and nerve paralysis is common. Sorry, it's not common, but it can happen, and it's mostly temporary. If it does happen, you are at higher risk for vaginal, perineal, and anal tears because your tissues don't have time to adapt to the size of the weight of the baby if we're delivering the baby very quickly. Okay. Other risks include shoulder dystocia, and you want to ask your providers about other risks that I don't really have time to delve into here. This is usually used as a last resort. So if your provider is suggesting that you use this, this is it. Okay, they're doing it because they're trying to save your baby's life. Okay, the most you could probably ask for is to push on your own like two more times, and that probably is it. But that is why they're using this again to have the baby being delivered very quickly if they're low enough, and it's just faster than getting a cesarean. Similar reason that we use forceps. Forceps are super duper old school. Providers don't use them anymore. Okay. But similar benefits. Okay. Similar risks and drawbacks. Okay. The only things that you might have internal lacerations here because the spoons go inside of you. So just like that picture that I showed you before, these spoons are going inside of you here instead of the vacuum being on top of the head. Okay. And here we have episiotomy. So episiotomy is just an incision into the perineum, all right? So we're making more room for the baby. Let's say you have a really tiny introitus that's not giving, it's not spreading, right? For the baby to be able to crown and be born, all right? Then we would do an episiotomy. This is incredibly rarely done. If you speak to a provider, like a doctor or a midwife who's been doing this for like 30 years, they'll say, oh, I've only done 2 episiotomies ever. like it's very, very, very rare. Okay. We would rather you tear naturally. Healing is more difficult than natural tearing here. Okay. You're also more likely to tear in that area again. Okay. Because the tissues are weaker. Again, it's used as a last resort and it's not widely used. And this is an emergency. That's why they're suggesting that you do it. Okay. It's not really more of a suggestion. It's kind of like, oh, we got to do this thing to save your baby's life at this point. Okay. So that's episiotomy. Okay. Last thing I'm going to talk about is the domino theory of an intervention. So I gave you all the risks and the benefits of everything here, right? The reason why I did that is because when you choose to do one thing, you're not just getting the benefits of it, you're getting everything that comes with it as well, okay? And a lot of times when you consent to one intervention, that means you're consenting to a bunch of other things that could, have you get more and more interventions throughout the duration of your labor. Okay, so that is why I do talk about the full picture with each one of these. Okay, so that's just a little bit about the domino theory of interventions. Next time, we're going to talk about cesarean birth, and we're also going to talk about birth planning. I like to kind of get through the medical interventions before we do birth planning, just so people have like a really good idea of what they prefer. Okay, and then we can, start like building those birth plans. Okay, right. That's it for me tonight, guys. Any additional questions? Kind of PCY and then second time touring that spot, like you said, from the scar. Yeah. Yeah. That does happen to a lot of people because it's really weak when they do that. Thank you. Thank you.
Awesome.
Appreciate
Awesome.
it.
Yeah, I had a episiotomy too, and it was and I had bruised my tailbone, so that was it. One
Tough.
child, one and done.
I hear you.
That was it. I was like, oh, that was an experience. And did it all natural. So
Oh,
it was
wow.
yeah. Yeah. So that
Oh, yeah, I know that hurt.
oh
I'm
yeah.
so sorry.
I gave everybody to the world, so I'm all set. Any questions, just drop them in the chat. We're going to go ahead and wrap up. Yeah, it was a really great presentation. I mean, I learned a lot too.
Thank you.
So let's see. We got a question from Nadi. She said, "Will you always be induced with gestational diabetes?"
That's a really great question. My experience, yes, you would. Because the concern there is that the baby will get too big to fit into the pelvis and into the birth canal. Okay. So those babies, they just grow really, really, really fast. So that's why we like to do it. And then also another piece of it is that babies who are born to mothers with gestational diabetes have low blood sugar. So we want them to be born in a controlled environment so we're able to help them, right? We're able to give them medications to manage that low blood sugar. Yeah. Okay. That was a great question. Any other questions?
Any
Interrupt,
other
maybe.
questions? Let's see.
Okay. Yeah, I see, Dalton, is there any way to somewhat control where a natural tear travels? My last birth, I tore up my labia, and if there's a way to redirect that, that would be great. So unfortunately, we can't predict that. However, you want to talk to your provider about things that they do to help guide the baby out. So a lot of providers will do like a labia, kind of like massage. That's the best way I can describe it. They kind of like stretch out that area. Okay. And then some of them will use like some sort of lubricant, like mineral oil or baby shampoo or something like that to help reduce that friction. Another great way is possibly pushing in a different position as well. That might help you out too. So if you push on your back, maybe push on hands and knees, and you can still push on hands and knees and on your side or something like that while you are well, if even if you have an epidural, the only thing you can't do with an epidural is stand. Okay. So that's just some things that you can do to reduce the risk of it, but I can't make any promises that it will 100% work. But that was a great question. Yeah. So the recording, Rita's gonna send you all the recording. Yeah.
Yes.
Mhm. And then how often such frequency of sex to help soften it to induce. So what we're doing is softening the cervix. Okay. It's not going to necessarily make you go into labor. It's just going to soften your cervix. So when you do go into labor medically or naturally, it will just be easier for your body to change. Like it will be easier for your cervix to dilate as much as possible, as much as you can tolerate it. That's how much you do. As long as the provider says that you can have sex, then absolutely do it as much as you can. Yeah, the only thing it's gonna do is help you. That was a great question. Okay, good. All right, cool.